can be quite glossy, it could be stretchy. A good way of describing a dead skin plug, you can compare it almost to chewing gum or dried up glue. It's got this elastic, stretchy property. Almost here, I'm really having to tug away at this, and it's almost stretching and elongating. So we're making good progress. They have got a narrow entrance in both ears, particularly their right side, which made the removal of the Keratosis obturans even more difficult because with it being a grade 3 Keratosis obturans, they had a really widened osseous portion of the ear canal, the bony part, whereas the entrance is really, really tiny and narrow. Let's say this is slightly wide at the entrance, but nonetheless still quite narrow. And as you can see, they've got a lot of hairs at the entrance now. This patient is of Asian descent, and it's probably just an anecdotal observation of mine, but I do find that patients of Asian descent do have more cilia, so hairs at the entrance of the ears. I know I do. My hairs are quite hairy at the entrance. And also males, so as men get older, you tend to have a build-up growth of more hairs, both at the entrance of the ears and up your nasal passages. I think the reason for that is men have a build-up of testosterone, which can then lead to hair growth, but the hairs, the follicles at the entrance of the nose and the ears, they almost desensitize to testosterone until later on in life, and when they become sensitive to testosterone, it then leads to additional hair growth in these areas and regions. So we're able to visualize the patient's eardrum there at 3 o'clock, and as is normally the case with dead skin, we're still trying to peel this away because it's quite sticky. It's that blue tinge. On the right side of the screen, that's the patient's, we'll classify as a posterior inferior portion of the eardrum. So in the case of the left ear, we'll can label it as the southeast region. So even at this stage, a patient could hear significantly better, but of course we want to remove this remaining skin. I'm trying to detach it from the roof of the ear canal there. And because of the sticky consistency, it can often block the suction probe. So quite often you can come out of the ear and using a cleaning rod or extruder and push it through the suction probe to unblock it. You can see that back part of the skin plug is still attached to the eardrum, so I'm just trying to remove this gently. Instead of just pulling it laterally, so getting a suction and pulling it straight away, you little wriggle movements like that, and you can just help to detach it. And of course, a bit of oil, so we use a bit of oil as well before, just to get it in behind that skin plug in the eardrum to lubricate it. So I brought it away from the patient's eardrum. It's now just a case of extracting it from the entrance of the ear, which is a bit more difficult than it would appear because also it's narrow, so I just have to wriggle this through. It's just detached from the main plug, that piece I removed there. I am taking short intervals with my narration here, so still got a bit of a sore throat. So I'm just pausing it, having a little break, and then coming back to the narration. There's another big plug there. And slowly but surely we're clearing this ear out. This is the last piece. So for quite a small ear, it did pack a lot of dead skin. That's another an obvious difference between earwax and dead skin. When you've got dead skin plugs in the ear, you can really compress a hell of a lot of dead skin in there, as opposed to earwax. I think with earwax there's a certain amount of wax that is possible to build up in an ear. With dead skin, because it can squash and fold upon itself, you can really extract a tremendous amount of dead skin, a lot more than you would envisage. So this is their right ear. When the patient attended, I treated the right ear first, but for the purpose of this video I wanted to show you the other way around so we can almost focus now just on the right side. So this patient 4 years ago had a blocked right ear. They went to visit another local specialist and he wasn't able to remove it, so they were referred to ENT and had a couple of attempts, a couple of appointments there, and eventually they managed to remove this. Now, ENT did advise the patient to use drops on a regular basis to soften his plug, but the patient hadn't been doing that. And then I saw this patient prior to me going away on my holidays. They woke up one morning and it was quite painful and they were really struggling to hear. They weren't aware that they had Keratosis obturans, so it was only once I started performing the procedure, as soon as that first contact with the plug, I immediately recognised it was Keratosis obturans. And so at the end of the appointment, sat down the patient, just discussed the condition, which I'll explain in a moment to everyone, and the appropriate aftercare with this, because this patient will need regular debridement of their right ear. So the entrance is quite narrow, so I'm using the endoscope to stretch it wide open, and that did actually make the procedure a lot more difficult because gaining access, and also with Keratosis Obturans you need the manoeuvrability with the instrument, so you've got a narrow entrance, it can constrict you somewhat. And as I mentioned, this consistency, something like chewing gum or dry glue is probably a better analogy actually. So what is Keratosis Obturans? Now it's a build-up, a very slow accumulation build-up of dead skin cells in the ear. And typically, when the skin cells in your ear die and shed, they separate into individual scales, if you like. So you think about the individual skin cells being like fish scales. Whilst they are alive and lining the ear canal, they're all interconnected. But as the skin cells die and go through a process called cornification, these individual skin cells, they separate and should flake off individually as it reaches the entrance. So this skin, it starts migrating from the eardrum, the outermost layer of the eardrum, which is made up of the epidermis layer of skin, which is the skin that lines the outer portion of the ear canal. The shedding process starts from the centre of the eardrum, so the dead skin on the eardrum, as it dies and sheds, it radially moves outwards from the centre of the eardrum, almost like the ripples in a pond when you drop a pebble. So imagine those ripples being dead skin, and then the skin, as it comes off the eardrum, it then slowly migrates from the deepest part of the ear canal, slowly but surely out of the ear. The rate of, we call it epithelial migration, that process, it's between 1.5 millimetres to 3 millimetres a month. There's obviously individual differences there, not only between ears, but individual people. But with the Keratosis Obturans, the skin, it tends to not separate the individual skin cells. It's still, so although the skin died and shedded, it's not individually flaking quite often with Keratosis Obturans, so they form what we call a lamellar structure. So lamellar structure, it's almost like an onion-like structure. So imagine you've got these sheets of dead skin lining the ear canal, and as they die, the sheets are still intact. All of the skin cells, individual skin cells, are dead, and they're separated from the canal wall. They've not separated from one another. And then you get another layer, a sheet of dead skin, and then another layer, a sheet of dead skin. And they overlap and interconnect, and it forms like an onion-like structure. And then this onion-like structure, it forms into a plug, and this plug gets bigger and bigger and bigger and bigger. Also, typically with Keratosis Obturans, the skin migration is abnormal, sort of the skin migrating from the deepest region of the ear canal to the entrance, so in a lateral plane. With Keratosis Obturans, quite often the skin, as it sheds and migrates, it migrates inwards into towards the centre of the ear canal, so it doesn't fully escape, and then it coils up these onion-like sheets of dead skin, coil over each other, forming a plug and a ball, a plug which just gets bigger and bigger. It's almost like a rubber ball. Now, the incidence rate of Keratosis Obturans, the data suggests 4 to 5 per cases that attend an ENT and audiology clinic. Now, I'll come back to it in a moment. Now, here you can see granulation tissue. So this bleeding is not due to myself making contact with the canal wall and causing trauma. Instead, this is one of the hallmarks of a grade 3 Keratosis Obturans, and I will go through the grading system in a moment or a bit later even, but you get the formation of granulation tissue. So when you then remove the plug of skin, this granulation tissue, it has its own blood vessels, they are ruptured, and you get what we call contact bleeding. So straight away, I know this is a grade 3 because that's, you wouldn't classify grade 1 or grade 2 Keratosis Obturans in the presence of granulation tissue. So I'm just using a Jobson horn. I'm also using the ear pick here, but it's just to stretch and elastic. And a bit later I'm going to use the forceps. The forceps did help at times, but other times it just separated bits of the skin plug. Instead of extracting it, it just plucked away little sections of it. But you saw there the ear pick was quite handy because it did bring the plug forwards. So I'm just alternating between the instruments. I've seen a little gap here where I can glide the ear correct in between the epidermis skin plug and the canal wall, and then rotating it and bringing it forwards. It's really quite dense and thick and stubborn material. So with Keratosis Obturans, 50% of cases are in both ears. It's not always bilateral. So in this case, for example, this patient's only got it in one ear. In terms of age, it's most common amongst patients who are below 40, the primary age between 20 and 40 years of age. And also, females are more prone to having Keratosis Obturans than males, and anecdotally, I can kind of somewhat confirm that as well through my own experience. I don't know the exact ratio, but certainly I do see more females with keratosis obturans than males. So the symptoms of keratosis obturans, the primary one is acute pain, so quite sharp, sudden acute pain. It's rather than a dull pain, so rather than a dull ache, it can be extremely excruciatingly painful for a patient when they present with keratosis obturans. And for that reason, sometimes it's not uncommon for keratosis obturans to be removed either under local or general anaesthetic. There are cases where that is necessary. Of course, when you've got keratosis obturans, you're going to have what we call a conductive loss. So what we mean by conductive loss, the organ of hearing itself, the cochlea, is relatively unaffected, but the sound can't reach the cochlea due to the obstruction in the ear canal. So when the sound can't travel through the ear canal or the eardrum to the cochlea in the inner ear, we call that a conductive loss. And in really severe cases, patients who present with keratosis obturans can suffer from facial palsy because it can affect the facial nerve if it's growing medially into the middle ear. Again, in extreme cases, it can cause damage to the organ of hearing. I've never come across a case that severe before, mind you. And it can also cause a dehiscence of a thin sheet of bone called the tegmen tympani, and that bone acts like a roof separating the middle ear, which is the cavity behind the eardrum, and the skull base. So when we mean by dehiscence, it can kind of cause damage to the bone. It can cause that thin plate of bone, tegmen tympani, to no longer be present. So rather than eroding it, it can just apply so much pressure that that bone undergoes a process called bony resorption. And I'm going to talk about that a bit more in a moment, actually. Another hallmark of keratosis obturans is a thickened eardrum, and that could be due to hyperkeratosis, which is quite common in cases of keratosis obturans. Hyperkeratosis is just a thicker layer of epidermis due to more keratin. So the epidermis layer of skin that lines lines most of your body, or lines all the skin on the body, the outer layer of skin, apart from the mucosal layer. It's got 5 layers, and the basal layer is where the individual skin cells can reproduce themselves, and the parent cell is then pushed upwards by the daughter cell until eventually it's the most outwards facing layer of that epidermis layer of skin. And as that parent layer is being pushed further and further away to the surface of the epidermis, it undergoes a process called cornification, and that's when that individual skin cell starts slowly but surely producing keratin. So keratin is a protein, and the outermost layer of skin, as it's going through that cornification process, all the functionality of that skin cell dies. So there's no more organelles, which give the skin cell its primitive life. All the intracellular fluid is no longer present, and instead that skin cell is just replaced and filled up with keratin. So keratin is the same protein you find in the fingernail and the hair strand. It has got some very useful benefits, actually. Keratin helps to reflect harmful UV sun rays. In addition, it's hydrophobic, so it helps repel water. Water is bad for the ear, so we don't want water in the ear because it can then lead to an ear infection. So some patients with keratosis obturans, they have high levels of keratin, which then causes a thickness of the eardrum as well, because remember the outer layer of the eardrum is an epidermis layer of skin. Sometimes patients can develop keratosis obturans because they just have a higher volume of skin cells in the ear, higher than average. And if you've got a higher than average number of skin cells in the ear, when they die, they can eventually then fall into a keratin plaque. So your ear just can't basically shift these dead skin cells at a quick enough rate because you just have too many to begin with. So the grading system of keratosis obturans, you get a grade 1 to a grade 4. So grade 1 is when a patient attends with mild pain, but upon removal of the keratosis obturans, you don't really see a noticeable expansion of the ear canal, so a widening of the ear canal. A grade 2 is when a patient attends with moderate to severe pain, and upon removal of the skin flood, you can see a mild expansion, widening of the ear canal. Now a grade 3, which is what this patient presents with, is again they've got moderate to severe pain. They've got moderate expansion of the ear canal, which this is what this patient has, and you can't see it at the moment, but you will do when I remove this plug. And importantly, the key distinction between a grade 2 and grade 3 is that they have granulation tissue present at the juncture of the ear, which is called the osseo-cartilaginous portion. So that's where the cartilage portion of the ear canal meets the bony part of the ear canal. So you can subdivide your ear canal into thirds. The outer third is made up of cartilage, the inner 2/3 is made up of bone. And where that cartilage and bone meet, we call that the osseo-cartilaginous portion or junction, and you get a build-up of granulation tissue there. And a grade 4 is when a patient attends with severe pain and severe expansion of the ear canal, which can extend to the mastoid region and also possibly affect the facial nerve. Now, you will see when I remove this patient is infringing on a grade 4 because they are beginning to develop early signs of an automastoidectomy. So the bone at the rear of the ear canal, so in this case it's the bone to the left, which is still not visible. That's the mastoid bone, and you can actually feel the mastoid bone if you get your finger and position it behind your ear. There's a flat surface there, we call that the mastoid process, but that's the mastoid bone. And the mastoid bone is a bone, it's porous, it's air-filled, it's like a honeycomb structure inside. So that's the back of the ear canal. So when you've got a grade 4 keratosis obturans, the widening of the ear canal can become so severe that the back part of the ear canal merges with the mastoid bone. We call that an automastoidectomy because there is a surgery called mastoidectomy where the ENT surgeons deliberately drill away the mastoid bone to remove, for example, a cholesteatoma, which is a very severe and serious ear infection. But in this case, there is elements that this posterior bone is merging with the mastoid bone. So you can almost classify that. I think I mentioned to the patient that they have a grade 3.2 keratosis obturans, although there's no such thing, but just to let the patient know that they are slowly developing into a grade 4. So it's very important that we keep on top of this moving forwards. Now, what causes this widening of the ear canal? Now, the cause, it can be twofold. It can be due to just the direct pressure of this plug. So when this plug of dead skin grows, there's so much pressure, physical pressure, that it literally just expands the bone. But more often than not, it's due to a process called bony resorption. And bony resorption occurs when, because of the pressure that's caused by this plug of dead skin, it causes a bit of inflammation to a part of the bone called the periosteum, which supplies, it's a thin sheet that lines the bony part of the ear canal. It supplies all the blood, the nutrients to the bone. And that physical pressure can kind of aggravate this periosteum, cause inflammation, which can then cause dilation of the blood vessels. And that can then activate a cell, a specialised cell sitting on the surface of the bone called osteoclasts. Now, what osteoclasts do, they're involved in the breakdown and dissolving of bony tissue and material and minerals. And then these bony tissue and minerals, they are released back into the bloodstream by the osteoclasts, so other parts of the body can reuse these the bony tissue and minerals. And that then leads to a remodelling of the ear. It causes a widening of it. In addition, the reason why people develop granulation tissue in cases of grade 3 and above keratosis obturans is, again, due to the inflammation caused to the periosteum by the skin plug. It causes a process called neovascularization, which is the formation of new blood capillaries. And when you've got inflammation, your body produces inflammatory cells called granulation tissue, and it's essentially connective tissue that has its own blood supplies caused by the formation of those new blood capillaries that I just described by the process of neovascularization. So when you remove a keratosis obturans, you're rupturing that quite often, that granulation tissue, and also those blood capillaries, so you get contact bleeding. In fact, we might have missed it, but I think when I removed, you might have seen a bit of granulation tissue at the entrance of the ear canal, and I suctioned it, so it's almost like it has a fleshy type appearance. So that's that big plug. And another characteristic of keratosis obturans, you would have just seen it there, the peripheral coating of the plug is a silvery white matrix, and that's the most recently shed layer of dead skin. So as the skin layer, you can see it, you've got dead skin on your finger, that's a good example. If it's just freshly dead skin around your fingertips or the bottom of your fingertips or around your nails, that skin is white in appearance, and then eventually, if it doesn't fall off and it remains there, you'll see it change colour. It goes through the oxidation process, it'll turn orange, brown, and then there's then black. So keratosis obturans, you just saw it earlier, that main plug, it was enveloped by the silvery white matrix, which is the most recently shedded layer of skin that's enveloped itself and added itself to the skin plug. What makes keratosis obturans also quite difficult to remove, because of that inflammation caused by the pressure of the plug compressing against the canal walls, it can then lead to inflammation, so edema, swelling laterally, so in front of the skin plug, which then again narrows the space. So this plug that I'm removing, it's probably 5 times the size of the entrance of the ear canal. So if you add inflammation to that, it just narrows the entrance. It makes it more and more difficult to remove. Now, generally speaking, there's 2 types of keratosis obturans. You get inflammatory type, which is caused by underlying inflammation. So again, when you've got inflammation